Assalamu alaikum, everybody. I do have one disclosure. First of all, it's very nice to see all of you. I kind of know you all by face, but I'm sure you don't know me. I'm one of the interventional consultants in PIC Peshawar. This is my first conference that I'm attending in Pakistan. I do have one disclosure. I asked my fellow to present this case for me, which he did in the last conference, which was conducted nationally. And he did win the prize, but I thought I'd present my own work, so that's why it's going to be, for some of you, it might be a replication, so I apologize in advance. So anyway, the patient's quite elderly, frail lady, 80-year-old. She presented with an acute coronary syndrome, very lightweight, and had some significant comorbidities. That's the ECG, which basically showed some widespread ischemic change. She's got poor LV function, with the internal dimensions maybe slightly dilated. Anyway, that's the coronary angiogram, with the diagnostic angiogram, which was conducted, I can't remember exactly, but I think it was another center. And then this landed at my desk or my OPD after a week or subsequently. So the patient did have significant disease, was very frail, poor LV function, already had bad kidneys, and had ongoing pain despite optimized medical therapy. So anyway, as my format dictates, I did consider, okay, well, the creatinine is already quite bad with a poor eGFR, and I was considering high complex PCI with an IVUS catheter. And that's just repetition of what I said, I think. We did get a formal surgical opinion in our center, and essentially they didn't want to touch her. So there is some data, some literature regarding ultra-low contrast or zero contrast PCI, especially with rotational atherectomy. Sorry, I forgot to mention the coronaries were actually quite calcified. I'm one of the rotor operators in our center. And so I was considering a slightly more adventurous case. I use IVUS quite frequently in our center. We're lucky enough that the Sehat card program has allowed me to frequently use the catheter. So I do rota and IVUS quite frequently, but I was a bit concerned about doing this using IVUS along with the rotablation because she was high risk. She was very frail, elderly, but my registrar very cleverly found some literature. There is some background data on this, including a case series which was conducted in the US. And what the data shows is that we can conduct PCI with relatively a small amount of contrast in this subgroup of patients. Surprisingly, there's data that's showing that even with contrast, this subgroup of patients can or may end up with renal replacement therapy if you go for full-blown contrast-mediated PCI. And there is some funny calculation. What they've done is they've tried to divide the weight by the eGFR, trying to estimate what's the allowed volume of contrast if you want to use contrast at all. I have to say I'm a bit skeptical about this, but when I was training, when I was being trained up by my consultants, I would consider anything, a 10 mil injection of contrast is a suitable enough dosage to assess things at the end. Anyway, so what I did was I used the wire. I already had the angiogram. I played the angiogram, had it set up for me. I kind of knew what my target was for angioplasty. I used two wires to just demarcate the circumflex and the LAD. I don't have pullback. I don't have the Philips pullback system or co-registration. So I was slightly guessing in the sense that I was using the old angiogram to decide where I was going to be stenting back from, which is the mid LAD essentially. And this is the IVUS catheter, and I'm sure I do have a run, or my registrar did put a run on, and he has. This is the pre-run. This is without any ballooning or anything, and you can see there's there's at least 100, 280 degrees of calcium over there, and quite mixed plaque, and quite severe calcium over there, about 180 degrees. A side branch coming into view over there. I'll just let this run. And these are some still pictures, and what this has showed is that, especially the second picture, is showing that there's 180 degrees at least calcium in the, I think in the mid LAD this was, and we got some reference images about the distal sizing of the LAD along with the left main reference. My plan was to essentially come back from the mid LAD back into the left main. Initially I did consider trying to land it in the body of the left main, but then that didn't make a lot of sense to me at all because there was no way I could tell that. So I decided that I'll just cover the whole ostium and ignore the circumflex. And just to demonstrate, really, just to make sure that we're not making it up in my mind at least, I usually, for especially calcific vessels, I just go straight up for NC balloons. I don't use SC balloons, and there was obvious dog boning, and I just, from that point, I decided to go to Rota. This looks like a slightly bigger burr, but I did my usual practice is I like to use a smaller burr first. I like to use a 1.25 burr first just to get a feel of what the lesion is like, how the patient's going to behave, and then after that I upgrade with the burr. I think the first picture is showing a slightly bigger burr. Right, what am I trying to find here? Oh yeah, okay, so following the rotablation, rotational atherectomy, I did do another one. Basically what I wanted to see or evaluate was what the ablation did, like how much ablation did I make, any calcium cracks, were they very evident, and they're probably not as evident. I remember this day I wanted to use a cutting balloon along with the rotaburr itself, but I didn't have that available, and even if I did, I probably wouldn't be able to use it because it's at the moment not available on the insurance program. But I thought I could see a few cracks. I knew that I'd modified the lesion, and I thought we were good to go for deploying some drug-eluting stents. So like I said, how I decided where I was going to stenting from was based on the angiogram that was conducted maybe a couple of weeks ago in another center. And as you can see, the stent's been deployed. There is some under expansion in this certain stent on the left of the picture. The trick over here, which I'll be honest with you, is I tried to use the circumflex wire to try to inform me where the ostium of the left main was. Initially, I thought I'm going to try to do this and land this in the body of the left main, but it was proving difficult. I kept on wiring, rewiring, and then I decided that I'm just going to cover the whole ostium, bring out the stent out into the aorta, and flare it up properly. Anyway, that's the final result. I think it's a reasonable result. I've lost a couple of diagonals, but the main thing was, we had an adequate result. I do have an IVUS run on a USB for the post IVUS. There is some under expansion in the mid LAD, but well, we don't have OPN balloons. I went quite high with an NC, and my usual rule is don't go for perfection. So I thought I would take this as a win. And I had a good result from the left main to the LAD, and I didn't want to do any further instrumentation. So the take-home message for me, I guess, and for the group, for us, was that we should always consider high-risk PCI, IVUS-guided PCI in patients who have abnormal renal function. We're lucky enough that we can use both technology in our centers. At the moment, we don't have the pullback system, but hopefully we can get that done soon. We did use the final injection that we took. It was less than 10 mils only. And that too, I think, if you look at the final picture, there was a slightly over-enthusiastic fellow because there was a lot of contrast that just shot out of the ostium. So I think we could have even left that, kept the contrast to probably about 6-7 mils, but that's the only contrast we used. Patient did fine, was discharged following that, and she did well. And that's it. Thank you so much.